And this one, we'll just do a recap of what we have on cholera, which is ongoing. We're going to talk about mpox. We're going to talk about, because like I did say, the periods for Lassa fever and meningitis are going to come up again because they are seasonal. We're going to talk briefly about what we are doing, what we expect people to do. The last one is the recent one in Rwanda, which is the Marburg viral disease. The reason being that we've been monitoring that, and like we know, Marburg and Ebola, they are similar diseases that are transmitted the same way, and they kill the same way. So it's essential that at least we let people know the first one. It's not here yet, and we hope it doesn't get here. But again, we need to prepare. So I will start that, well, we appreciate your presence at this briefing. And our gathering again underscores that NCDC's unwavering commitment to safeguarding the health of Nigerians by providing essential updates on infectious disease outbreaks, both within our borders and globally. And our goal remains clear: to empower Nigerians with accurate information that fosters proactive decision-making in the face of public health challenges. Over the past months, NCDC has been deeply engaged in managing a wide range of infectious diseases, including cholera, yellow fever, diphtheria, mpox, and more recently, monitoring the global Marburg virus outbreak in Rwanda. In alignment with the national seasonal hazard prediction, we are also intensifying our preparedness for the upcoming Lassa fever and cerebrospinal meningitis seasons, both of which remain significant threats to public health in Nigeria. Firstly, we address cholera outbreak currently affecting Nigeria. Cholera, as we know, remains a serious public health issue, particularly in areas with inadequate water, sanitation, and hygiene systems, wash systems. And the NCDC, in collaboration with relevant stakeholders like the MDs, Ministry of Environment, Ministry of Agriculture, and other partners, have been working tirelessly to mitigate the spread of these and save lives. As of October 13, about 3 days ago, a total of 14,237 cases of cholera have been reported across 35 states and the Federal Capital Territory, and they span 339 local government areas. Sadly, 378 lives have been lost, resulting in a case fatality rate ratio of about 2.7%. The burden of this outbreak disproportionately affects the most vulnerable, these are children under the age of 5. This year has seen 2 significant waves of cholera, with the most recent surge reported during the week of September 29, Epi week 39, attributed to the heavy rains and subsequent flooding. This pattern we had anticipated, if you remember the last press briefing, having foreseen the risks through data and advisories provided by the Nigerian Meteorological Agency, NIMET. The floods in the northern states such as Borno, Adamawa, Jigawa, Yobe, and Kano have exacerbated the spread of cholera, making these states the current epicenters of this outbreak. Earlier in the year, the cholera cases were concentrated in southern states as the rains began there, but we have seen a shift, with the northern states now accounting for a significant proportion of the cases. The number of suspected cholera cases and deaths in 2004 has more than doubled when compared to this time last year. And that is where we are extremely worried. I know it was predicted earlier by NIMET that this year alone the rainfalls will be heavier than we've experienced. These numbers reflect the severity of the outbreak and reinforced the need for continuous vigilance and action. It also underscores the developmental issues that should be addressed both at the national and subnational levels, with the improved commitment towards addressing challenges relating to inadequate access to clean water, open defecation, poor environmental sanitation, food and personal hygiene. I need to state it again. The control of cholera is more of a developmental issue. In situations where we don't have access to water, where hygiene is not fully addressed and environmental sanitation is not addressed, we will continue to have that. And that's why it's essential that this thing is emphasized. In response, we've deployed our rapid response teams continuously, including experts from our One Health line ministries to the affected northern states. These teams have been instrumental in coordinating with and supporting the local response by guiding interventions and providing critical supplies, including medicines, water purification tablets, infection prevention and control materials, and diagnostic tools. High-level advocacy visits, especially to the Borno state because of a flood, were conducted to engage the state's health leadership, encourage response teams, and offer our support to communities displaced by the floods. The second day after this flood happened, our team, the first team, went to Borno State to assist the Ministry of Health in this response. We sent a second team about 2 or 3 weeks later because they needed our support, which we did. And like we said again, we also provided at least 2 truckloads of materials to support them from our stockpile. Our efforts have been bolstered by collaboration with the National Primary Healthcare Development Agency. Together, we have successfully supported our sister agency, the NCDC, to carry out reactive cholera vaccinations in the internally displaced persons camps, a move that has proven crucial in reducing the cases being reported. We urge all Nigerians to practice again good personal, food, and environmental hygiene, with emphasis on regular hand washing with soap and water under running water, and more importantly, seek medical care immediately if cholera symptoms, such as diarrhea and vomiting, occur. Like we said again, what kills in cholera is the loss of fluids from the diarrhea. If medical attention is sought early, and these people have immediately rehydrated, they will not die. So people must present early to healthcare. Looking ahead, our priorities remain clear. We will continue to enhance surveillance, improve prompt treatment of affected persons, and strengthen water, sanitation, and hygiene practices in the affected communities. Cholera is a preventable disease, and with the collective effort, we can control and eventually eliminate this spread. Our next one is Mpox update. In response to the increasing threat of Mpox, especially in the light of regional cross-border transmission, the NCDC has reinforced its strategies to prevent the spread of the disease and the virus. We are primarily dealing with the clade 2B variant, which is circulating in Nigeria. However, we are also monitoring the situation in the Cameroon, where both clade 1B and clade 2B are reported, and also hiding our surveillance from the clade 1B, a more severe strain currently circulating in Kenya, Uganda, Burundi, and the Democratic Republic of Congo, which has the potential for rapid spread through community transmission. Turning to Mpox, Nigeria has continued to manage the outbreak with vigilance. As of the 13th of October, a total of 102 confirmed cases have been reported across 26 states and the Federal Capital Territory, from about 1,339 suspected cases. Encouragingly, there have been no recorded deaths so far, and we remain cautious. The observed steady rise on the number of reported cases in recent weeks can be attributed to enhanced surveillance and improved case detection across the country. The more you seek, the more you find. But the essential is that if you let the people know how Mpox presents, what the signs are, and sensitize our health workers so that they can easily be detected and put to treatment. So our response strategy rests on the several key pillars: stakeholder engagement, as involving our partners, international agencies, to align our efforts and strengthening collaboration and coordination. Like I said, we are particularly focusing on cross-border collaboration to prevent importation of more severe Mpox variants. Coming to surveillance and diagnostic capacity, we continue to enhance surveillance across the country through active case search, and that's why we are seeing more cases. Our ports of entry, including the airports, are closely being monitored, and passengers are required to complete the health declaration forms. Additionally, we are optimizing laboratory diagnostic capacity by expanding molecular testing facilities in strategic states such as Enugu, Cross River, and Bauchi. Our partnership with the International Federation of the Red Cross has also enabled us to train 55 public health workers across 11 states to bolster our response efforts. On community engagement, public health advisories, jingles, pamphlets, and community mobilization efforts are ongoing across the country. This one, the states themselves are doing, so some of these are being domesticated in various states across the country. We are also working closely with states to disseminate Mpox awareness materials in various languages, ensuring that information reaches even the most remote areas. On vaccination, which many of us have asked questions about, in partnership with NCDC and NAFDAC, we are facilitating the deployment of the 10,000 doses of Mpox vaccine, prioritizing high-risk groups such as contacts of confirmed cases and the immunocompromised individuals. Priority states for this vaccination campaign include Bayelsa, Rivers, Cross River, and Akwa Ibom, based on the burden of Mpox cases reported since 2017. Anyone with rash illness is advised to visit the nearest health facility for care, and the general public is advised to avoid direct contact with sick or dead animals, avoid consumption of undercooked meat or animal, whatever it is. On last year, 2024, we have recorded about 1,018 confirmed cases of Lassa fever, and unfortunately 172 deaths, with the majority of cases reported from Ondo, Edo, and Bauchi states. While the peak of Lassa fever outbreak was declared over in April, sporadic cases continue to be reported, with 37 new cases and 4 deaths recorded in the past month alone. This reaffirms that Lassa fever still remains a persistent health threat, particularly as we approach the dry season and when cases typically surge. To mitigate this risk, we are strengthening our preparedness for the oncoming Lassa fever season. We have reviewed our response to the previous outbreak. We've identified lessons learned to enhance future interventions. Our findings have identified that kidney failure as a major cause of death from Lassa fever. In addressing this, we are training health workers at both the state and local governments. These trainings are ongoing to ensure rapid case detection, accurate reporting, and effective management. Like I did say, that's what kills in Lassa fever, kidney failure. So if we sensitize our health workers in various hospitals to be on the lookout, and once a case is diagnosed, they know precisely what to do. Along this line, we have procured and installed 12 dialysis machines across our treatment centers because of kidney failure. Additionally, we are stockpiling essential medical supplies such as personal protective equipment, medicines, and diagnostic tools in high-risk states to ensure a swift response should an outbreak occur. It's also a seasonal threat that peaks between January and April. We're in October now. We will have November and December. While projections for the upcoming CSM season suggest a moderate number of cases from projections, we will not take any chances. Along this line, Over 400 healthcare workers across 9 states have been trained in case management and cerebrospinal fluid collection, which is essential for accurate laboratory diagnosis and effective treatment. Let me emphasize this. We have cases in most of those CSM infected states. What we've discovered is that majority of deaths from those diagnosed are very high. But we also know that a lot of cases were not diagnosed because our doctors could not take the proper samples in various hospitals. And that's why, again, when a patient is suspected of having meningitis, you do a lumbar puncture based on the signs you see. Lumbar puncture is tap at the back of the back to get cerebrospinal fluid and test. That's the diagnosis. Now, because a lot of our workers in that part of the are not trained in this, that's the essence why we needed to train them. That is what we are doing. So, additionally, we are conducting operational research in collaboration with our partners and community stakeholders for after-action reviews to ensure that our response strategies are both evidence-based and cost-effective. Part of that is that some people, in the vaccines, the new vaccine they are using, the pentavalent, some people, because it's relatively new here, that's why the research is ongoing again to see again how effective it is for those of them that have been vaccinated compared to those not vaccinated or used, or who are used to the previous vaccinations. On the Marburg virus update, on the global front, we are closely monitoring the Marburg virus outbreak in Rwanda. As of October 15, 62 cases have been confirmed in Rwanda and 15 fatalities. The virus, which is highly infectious and similar to the Ebola virus, and following an expert risk assessment, when we heard of the cases in Rwanda, we normally call our technical working group to do a risk assessment. That is, what will be the risk profile in Nigeria? Should we have that kind of thing? So we conducted, and they adjudged that the potential for local transmission is there. So that risk has been put at moderate. But again, we would not rest on our oars because there's a potential for localized transmission, particularly amongst the populations with high presence of bats and where bats are being used as delicacies. If the virus is imported into Nigeria due to the volume of travel between two countries, while there is no specific treatment of vaccine for Marburg, just like Ebola, you do symptomatic treatment, just supportive therapy. The same thing for Marburg. However, we are planning again a response, a reason alert for response. So working with our stakeholders across ministries, departments, and agencies of government, we have activated health declaration forms again at the ports for incoming passengers, especially from affected regions, and are ready to isolate suspected cases immediately upon detection. Additionally, we have identified isolation centers and commenced the process of stockpiling the necessary medical supplies to handle potential cases. Like I did say again, Marburg and Ebola, even Lassa fever, are similar in presentation. We urge all Nigerians to remain vigilant, particularly those traveling to regions with reported Marburg cases. Avoid contact with wild animals, especially fruit bats, and seek medical attention immediately if symptoms such as high fever, severe headache, or unexplained bleeding occurs. That's why they are called hemorrhagic viral disease, because they bleed. The preventive measures adopted during the Ebola outbreak in Nigeria, such as regular proper hand washing with soap and under running water, or use of alcohol-based hand sanitizers, is applicable for the prevention of Marburg viral disease. On other health events, we are fostering strategic partnership with key stakeholders, including the National Council on Climate Change and the Nigerian Meteorological Agency, NIMED, to enhance our capacity for climate-informed decision-making. Through seamless real-time data sharing and coordinated collaboration, We seek to bolster our preparedness and response to climate-associated health risks, including floods and droughts. If I may explain this further, NIMET and their group, they look at specific factors. They look at rainfall, they look at humidity, they look at temperature. And using statistical modeling, they can tell us, predict again, based on other factors again, when we expect this kind of thing to occur based on flooding and where we expect to occur. Now, collaborating with them now with our own factors or knowledge on disease symptoms, right? Presentations, etc. Again, we can modify that again to actually predict using mathematical modeling when we expect Lassa fever to occur. It might not be 100% correct, but again, we have a fair chance of it. When do you expect meningitis, or how heavy do you expect this is to happen? That's that kind of collaboration we're dealing with NIMET. This proactive approach further underscores our unwavering commitment to safeguarding the health, well-being, and resilience of Nigerians amidst an ever-evolving global health landscape. In closing, ladies and gentlemen, the NCDC remains at the forefront of the fight to protect public health in Nigeria, and through coordinated efforts with local and international partners, we are committed to providing the highest level of protection against these disease threats. As we conclude today's briefing, I must emphasize that public health is a shared responsibility. I will say it again, shared responsibility. National government, state government, private organizations, the communities and individuals must continue to collaborate with each other to strengthen our health system. The need for preventive measures, such as we could emphasize that, such as regular hand washing, keeping clean environment, including rodent control, avoiding direct contact with sick or dead animals, adhering to food and personal hygiene practices, and seeking care early when symptoms of any of the above listed diseases of public health importance are noticed cannot be overemphasized. In fact, that is the major reason why we're holding this. We need to pass on these messages to our people. May I also use this medium to advocate for improved commitment of all state governments for timely reporting of these diseases of public health importance. This will by no means help our timely intervention and contribute to effective and the judicious use of our limited resources. Let us raise the bar of our commitment, intensify sustainable effort across boards, ensure timely adherence to public health advisories, contribute to a well-informed communities, and practice all preventive measures not only during outbreaks, but even beyond. Together, we will overcome these challenges and build a stronger, healthier Nigeria. I thank you all. May God bless our Federal Republic of Nigeria. One more thing on Maybach. For people to know, there's what they call a case definition of every disease. You have the case definition of Maybach? Okay, we shall circulate that again with the whatever. It's very essential so that people will again, that's what we use again for most diseases here. You do case definition for these diseases. But sorry, yeah. A suspected case for Maybach. Any person with a history of fever or temperature greater than 37.5 degrees centigrade in the last 48 hours, and or any three of the following symptoms: headache, body weakness, loss of appetite, aching muscles or joints, abdominal pain, difficulty in swallowing, vomiting, difficulty in breathing, diarrhea, and a history of travel within the last 3 weeks to a country reporting any suspected or confirmed cases of Maybach virus disease, MVD. That's one. Or any person with inexplicable bleeding and a history of travel within the last 3 weeks to a country reporting any suspected or confirmed case or cases of Maybach viral disease. Or any person with a history of fever, temperature greater than 37.5 degrees centigrade in the last 48 hours, with or without any of the following symptoms: headache, body weaknesses, loss of appetite, extra vomiting, and you always have that history of contact within the last 3 weeks with a confirmed or probable case of MVD. That's for definition for suspected case. When you have those again, a suspected case, you must investigate. Or probable case, any suspected case, diseased or alive, where specimen for laboratory confirmation was not collected, and with an epidemiological link to a confirmed case. And the epidemiological link, is it family link, is it contact, etc. The second one, laboratory confirmed case, we will give you some of this again in a press release again. Any suspected case or probable case with a positive laboratory result, that's laboratory confirmed. Just like any other disease, like I just mentioned the meningitis. You can have suspected case, but again, once you do that detection, you confirm the case, confirmed case. So, positive laboratory result. Laboratory confirmed cases must test positive for the Marburg virus antigen, either by detection of, okay, these are specific, these are laboratory confirmed. It's just essential. We shall put it again as part of the press release to assist in disseminating. Thank you very much.